Imagine this. His name is Robert. He's 74. He retired 2 years ago after 4 decades as a civil engineer. He walks 3 miles every morning. He tends a small garden. He sleeps well. His wife says he's the healthiest man she knows. One Tuesday in October, Robert goes in for what he describes as just a routine check. His doctor is thorough, professional, careful. During the visit, an incidental finding appears on a scan, a small shadow, probably nothing. But the protocols require they investigate further. One test leads to another, then a biopsy, then a specialist, then a second opinion. Over the next 4 months, Robert undergoes 3 procedures. He misses his walks. He stops gardening. His wife watches the light in his eyes dim, not from illness, but from anxiety, from the weight of the system that has now, with good intentions, taken hold of him. The final result? The shadow was benign. It had been there for years. It would never have caused him harm. But by then, the damage to his quality of life and to his sense of self was already done. He didn't come in sick. He left changed. Robert's story isn't a horror story. It isn't even unusual. It is quietly, routinely happening in doctors' offices and imaging centers across this country. To people who are healthy, careful, and simply doing what they were told was wise. And today, we need to talk about it. Welcome. If you're watching this, you're probably someone who takes health seriously, or someone who loves a person over 70 and wants to make sure they're protected. This channel, Ava Health Nexus, exists for exactly this reason: to bring you the kind of nuanced, evidence-grounded conversation that doesn't always happen in a 15-minute appointment. What we're going to discuss today isn't about avoiding medicine. It isn't about distrust. It's about something more precise. It's about what researchers are beginning to call the longevity lens. The idea that the same medical test can carry an entirely different risk-benefit ratio depending on your age, your overall health, and your individual goals. A test that saves lives at 50 can, in specific circumstances, reduce quality of life at 75. This is not opinion. This is published science. We're going to walk through 5 medical checkups that major medical organizations have reconsidered for adults over 70. And we're going to do it carefully, clearly, and with full respect for the complexity involved. Because context matters, individual risk matters, and your right to an informed conversation with your doctor matters enormously. Before we get to the 5 checkups, we need to understand something fundamental, something that most patients, and even some physicians, don't pause to fully consider. The purpose of medical screening is to detect a problem early enough that treating it will improve your outcome. That logic is sound, but it rests on a set of assumptions, and after 70, some of those assumptions begin to shift. First, time horizon. A cancer detected at 55 might take 15 to 20 years to affect a person's life. Detecting it early creates enormous opportunity for intervention. But a slow-growing cancer detected at 78? The math is different. The treatment may carry risks that outweigh the benefit of catching something that might never have caused symptoms within a natural lifespan. This isn't a dark thought. It's the kind of clear thinking that leads to better, more humane care. Second, cascade risk. As we age, our bodies become more sensitive to procedures, to anesthesia, to contrast agents, to biopsy complications. An incidental finding on a scan can trigger a cascade of further tests, each carrying its own small risk and collectively capable of doing real harm. Third, overdiagnosis. This is perhaps the most misunderstood concept in modern medicine. Overdiagnosis means detecting a condition, a real one, that would never have caused symptoms or shortened life. It's not a misdiagnosis, it's a real finding, but treating it carries risk, while leaving it alone would have been the wiser choice. Keep these three ideas in mind, because they are the quiet engine behind every checkup we're about to discuss. Meet Gerald. He's 76, active, sharp. His annual physical has always included a PSA test, a blood test measuring a protein that, when elevated, can be an early signal of prostate cancer. Gerald's test comes back slightly elevated. He's referred to a urologist. A biopsy follows. The result reveals a very small, very low-grade cancer. He's told he needs treatment. What Gerald isn't told, at least not clearly, is that many men his age carry exactly this type of slow-growing prostate cancer and will never experience a single symptom from it. They live full lives. They die from something else entirely, decades later, with the cancer still quietly present and completely unthreatening. The United States Preventive Services Task Force now recommends against routine PSA screening for men 70 and older. Not because the test is bad, but because the harms of what follows often outweigh the benefits at this age. The treatments for prostate cancer, surgery, radiation, carry real risks: incontinence, erectile dysfunction, bowel complications. In a younger man, those risks may be well worth accepting to stop an aggressive cancer. But in a 76-year-old man with a slow-growing tumor that may never progress, the calculation is genuinely different. This doesn't mean Gerald should refuse all prostate care. It means the conversation should be richer. It means his doctor should explain what kind of cancer was found, how fast it grows, and what the realistic options, including careful, watchful waiting, actually look like. The question to ask your doctor: if this test comes back elevated, what would the next steps be? And given my age and overall health, what does the evidence say about whether treatment would actually improve my life? Now, to be clear, monitoring blood pressure after 70 is important. This isn't about abandoning a vital sign. This is about something more specific and more nuanced. Her name is Miriam. She's 81. She has mild hypertension. Her blood pressure runs slightly above the standard threshold. Her physician, following updated guidelines designed largely for younger populations, increases her medication to bring the numbers down more aggressively. Within 6 weeks, Miriam feels dizzy when she stands. She catches herself on the kitchen counter twice, and one afternoon, reaching for a shelf, she falls. She breaks her hip. For older adults, overtreated blood pressure can be more dangerous than mildly elevated blood pressure, and the research, including findings from major cardiovascular trials, is increasingly clear on this point. In younger adults, the brain can compensate quickly when blood pressure shifts, but in an 81-year-old, that compensation slows. Blood pressure that's been lowered too aggressively can reduce blood flow to the brain upon standing, a condition called orthostatic hypotension, creating dizziness, instability, and the very real risk of a devastating fall. Some of the most important geriatric medicine guidelines now recommend individualized blood pressure targets for older adults, acknowledging that 120/80 may be the ideal for a 55-year-old, but may not be the right goal for someone in their 80s with existing mobility or vascular concerns. The question to ask: is the blood pressure target we're aiming for calibrated specifically for my age, my fall risk, and my overall physical condition? Or is it based on general population guidelines? Colonoscopy has been one of the most powerful tools in cancer prevention in modern medicine. For adults between 45 and 75, it has saved countless lives by catching colorectal cancer early, or preventing it entirely by removing precancerous polyps. But here's what most people never hear. At 75, the calculus begins to shift. The American Cancer Society, the U.S. Preventive Services Task Force, and several leading gastroenterology groups have all noted that for adults over 75, particularly those with average risk and no prior polyp history, the evidence that routine screening improves outcomes becomes significantly weaker. By 76, the procedure itself carries more risk than it did at 56. And the window of benefit, the time needed to actually benefit from catching something early, is narrower. The bowel preparation required for colonoscopy can be physically taxing: dehydration, electrolyte disruption. In frail or older patients, these can be serious. The sedation required also carries higher risk as we age. And the perforation risk, while small, is real and more consequential in an older adult. This is not a call to abandon colorectal cancer awareness. For an adult over 75 who has a family history of colorectal cancer or who has previously had significant polyps, continued surveillance may absolutely be warranted. The decision must be personal. But for many adults in this age range, particularly those who have had prior clean screenings, the evidence supporting continued routine colonoscopy is thin. The question to ask: given my personal history, my overall health, and my age, does the current evidence support continuing this screening? And are there lower risk alternatives we should consider first? This is perhaps the most delicate conversation in this entire script. Because mammography has been, and continues to be, one of the most important tools in women's health. This must be said clearly, and it must be heard. But nuance demands that we also share what the research has been quietly indicating for more than a decade. For women over 75, no major randomized clinical trial has yet demonstrated that continued routine mammography screening reduces breast cancer mortality. The trials that established mammography's benefit were largely conducted in women between 40 and 74. The extension of those findings to women in their late 70s and beyond is, scientifically speaking, an extrapolation, not an established fact. The American Geriatric Society notes that the potential benefits of mammography screening decline with age, while the risks, including false positives and the anxiety and procedures they trigger, remain constant. Here is the reality that's rarely spoken aloud. False positive rates from mammography are significant. Roughly 10% of mammograms result in a callback for additional imaging. Many of those lead to biopsies, and biopsies cause real stress, real physical discomfort, and in some cases, real medical complications, even when the ultimate finding is benign. For a 52-year-old, that cascade, anxious as it is absolutely worth it, because early detection can provide 20 or 30 years of additional healthy life. For a woman at 79 in good health, the calculus must be deeply personal, tied to her family history, her breast tissue density, her life expectancy, and most importantly, her own values and preferences. This isn't medicine being indifferent. This is medicine, at its best, respecting the whole person. The question to ask: given my age, my overall health, and my personal history, what does the current evidence suggest about whether continued routine mammography is likely to benefit me, and what would be the plan if something were found. For decades, the goal in managing type 2 diabetes was clear: get the HbA1c, the 3-month blood sugar average, as low as possible. The lower, the better. The logic made sense. High blood sugar causes damage over time. Bring it down. But here's what the landmark Accord trial and several studies that followed it revealed, in findings that genuinely shook the medical community. Aggressive blood sugar lowering in older adults with diabetes was associated with higher, not lower, rates of cardiovascular events and mortality. Treating the number too aggressively created a new danger: hypoglycemia. And in an older adult, a sudden drop in blood sugar can cause falls, confusion, loss of consciousness, and even cardiac events. The American Diabetes Association now explicitly recommends less stringent HbA1c targets for older adults, particularly those with limited life expectancy, significant other health conditions, or a history of severe hypoglycemia. The goal has shifted from optimizing a lab number to optimizing a life. For an active, otherwise healthy 71-year-old with a long life ahead, tighter control may still be absolutely appropriate. But for a frail 82-year-old with multiple health conditions, relentlessly chasing a lower blood sugar number can cause genuine harm. Harm that's quieter and less visible than the disease it was trying to prevent. The question to ask: is the blood sugar target we're working toward appropriate for my age and overall health? And what are the specific risks of hypoglycemia for someone in my situation? Before we close, I want to give you something practical, something you can take into your next appointment or your parents' next appointment and use. These are 5 questions that reflect the most important principles of age-conscious medicine. They're not confrontational. They're not about distrusting your doctor. They're about opening a richer, more honest conversation. 1. What would happen if we didn't do this test right now? Understanding the consequences of watchful waiting often reveals that urgency is less than assumed. 2. Is this screening guideline designed for someone my age, or is it based on younger populations? Many guidelines were built on data from adults under 70. Your doctor should know the difference. 3. What is the realistic chance this test leads to a procedure? And what are the risks of that procedure at my age? Cascade risk is real. Asking about it directly brings it into the open. 4. If something is found, what would our plan actually be? Sometimes the honest answer is, we'd monitor it. If that's the plan regardless, the test may be unnecessary. 5. What does a good outcome look like for me? Not in terms of numbers, but in terms of how I actually live. This is perhaps the most powerful question of all. It reframes the conversation around quality of life. These questions don't require a medical degree to ask. They require only the conviction that your well-being is worth a fuller conversation. And it is. It always is. Medicine, at its best, is not about numbers on a chart. It is not about ticking boxes or following protocols for their own sake. It is about a human being, with a name, a history, a garden they tend, a walk they love, being helped to live as fully and freely as possible for as long as possible. The tests we discuss today aren't villains in this story. They are tools, remarkable, life-saving tools when used thoughtfully and appropriately. What we've been asking is simply this: are they always being used with the full context of who you are and what stage of life you're in? The goal of medicine after 70 is not just more years. It is more life, more presence, more vitality, more peace. Remember Robert from the beginning of this story? He's back in his garden now. He walks in the morning again. His wife says the light has returned. He found a physician who was willing to sit with him, without a clock running, without a protocol to rush through, and ask the single most important question in all of medicine. What does a good life look like for you? And how can I help you protect it? That's the conversation we all deserve. And now you have a little more of what you need to ask for it. If this conversation opened something for you, a new question, a new perspective, something you want to bring to your doctor or your family, I'd love to hear it in the comments below. Your experience matters. Your voice adds to this conversation in ways that benefit everyone watching. Subscribe if you'd like to continue this kind of thoughtful, honest dialogue about health at every stage of life. We'll be here, calm, careful, and always on your side.